First of all, thank you to the organizers for inviting me to present on behalf of all of my co-investigators. The title of our talk is RSV Transplacental Antibody Transfer and Protection from Infection in Mother-Infant Pairs in Nepal. And this study was done in collaboration with Mark Steinhoff, Jim Tilsch, Amalia Margaret, Subarna Khatri, Steve Leclerc, Lakshman Shrestha, Daisy Matsudan, Jane Kuipers, Joanne Katz, and Jan England at a variety of institutions, including the Nepal Neonatal Intervention Project, Cincinnati Children's, Johns Hopkins, Seattle Children's, and the My Institution at the University of Washington. Good, great. So higher concentrations of maternal RSV-specific antibody are associated with protection from infant hospitalization. We know that RSV antibody half-life is estimated at approximately 36 to 42 days, with an increase in cord blood antibody titer associated with a decreased risk of serologic RSV infection. Maternal vaccination may be used as a strategy to extend the period of protection in young infants through transplacental antibody transfer after vaccination in the third trimester, and protect young infants for a longer period before their primary RSV infection. We know that the greatest burden of RSV disease is in developing countries. However, we do not know what the effect of RSV antibody is on virologically confirmed RSV infection in developing countries, particularly in places with a high incidence of low birth weight and preterm births. So the aims of our study were to characterize the factors associated with transplacental antibody transfer in Nepal, and particularly to evaluate the effect of preterm birth on RSV cord to maternal antibody transfer ratio. Next, we wanted to evaluate the relationship between cord blood RSV antibody titer and risk of RSV disease in the infants in Nepal, to look at the relationship between the cord blood antibody titer and RSV infection risk, and then among those infants who then did develop RSV in the first 6 months of life, to see if a higher antibody titer was associated with a decreased risk of lower respiratory tract infection or a delayed time to first infection. So our study was done within the infrastructure of a maternal influenza immunization trial that was conducted in rural southern Nepal from 2011 to 2014. This was in a rural subtropical setting where 25% of the infants are born low birth weight, which we defined as less than 2,500 grams, and 15% were preterm, born at less than 37 weeks gestation. Women were enrolled in their second trimester of pregnancy, although we started surveying all women of childbearing age in the study area, and determined the gestational age of birth of their infants based on the last menstrual period, which we obtained by recall through monthly surveillance of all the women and testing of using a urine pregnancy test on all women who had missed their period. We then performed longitudinal household-based active weekly surveillance for respiratory illness in infants until 6 months of age. And this involved a data collector going to every household every week and asking about symptoms of respiratory illness in the infants over the last 7 days. And any infant who had a respiratory illness had a nasal swab collected. Infant weights that were obtained within 72 hours of birth, which was the majority of the weights, were included in our results. And the majority of the births in our study were home births. So we defined respiratory illness in infants in our study as the presence of any one of the following: subjective fever, cough, rhinorrhea, wheeze, difficult or rapid breathing, or otorrhea. In these cases, we collected a mid-nasal swab and we performed a clinical exam. We defined a lower respiratory tract infection as cough and or difficulty breathing, plus age-specific tachypnea according to the WHO criteria, or wheezing. And then we also used the WHO criteria for staging of severe or very severe pneumonia. So we collected maternal and infant cord blood at the time of delivery in a subset of 299 mother-infant pairs from a total of 3,646 mother-infant pairs. We measured their RSV neutralizing antibody concentrations using an antibody assay developed with the assistance of Ed Walsh and Ann Falsey at the University of Rochester, where we incubated two-fold dilutions of the serum against the RSV-A2 virus prior to the addition of Hep2 cells, and then we developed this on day 3 using an ELISA against the RSV-F. We defined the endpoint titer as the 50% cutoff between the positive and the negative controls, and then we estimated the antibody concentration at the time of RSV infection in the infants based on decay rate of the antibody of a log base to 0.026 per day, based on prior studies that we had done in Bangladesh. And then we tested the nasal swabs that were collected during the respiratory illness episodes in the infants for RSV, as well as 11 other respiratory viruses using an RT-PCR assay. So this is a summary of the overall study results looking at RSV infection in these infants. So we enrolled 3,646 infants at the time of birth, and we followed them for 1,483 person years. 311, or 9% of these, had a primary RSV illness episode within the first 6 months of life. 220 of them, or 71%, had a healthcare visit. And this was in a location in rural southern Nepal where there wasn't much in the way of healthcare. The closest hospital is about an hour away. And 41, or 13%, were seen at a hospital or by a physician. And we had one death due to RSV. And this infant was 31 weeks, was a 31-week preterm and did not present for care. So the death was based on surveillance done in our study. So 287 infants had clinical staging performed, and 203 of these had met criteria for lower respiratory tract infection. And then in a subset of 246 infants, we were able to do the WHO staging within 2 weeks of their first RSV PCR positive illness episode. And in those, we found that 6 of them met criteria for severe pneumonia, and 24, or 10%, had very severe pneumonia. So this is a graph showing the seasonality of RSV in our study over the 3 years of surveillance. So you can see that the RSV is in the dark blue bars, and the light blue bars represent all of the illness episodes in the infants. And RSV was quite seasonal in our study over the 3 years of surveillance, with a peak between September and March over all 3 years. We found that the season of birth, not surprisingly, so the period of birth, if you were born during the monsoon season, which preceded the RSV season, then you were at the highest risk for RSV infection. We also wanted to look at incidence of RSV by age group, and we found that, so the graph on the left shows incidence by age at infection, and you can see that most of the infection in these infants occurred between 1 to 4 months of age. When we looked at the graph on the right, which shows the incidence of RSV by gestational age at birth, we found that the highest incidence of RSV was in infants who were born between 20 to 31 weeks, and that this decreased significantly by the time they were full term, with a p-value of 0.017. And I would just point out that 30, or 10%, of the infants with RSV were born before 4 weeks of gestation, a time when they are unlikely to benefit from too much transplacental antibody transfer. So we've analyzed to date, so we've collected samples from the 299 mother-infant pairs from March of 2012 until December of 2013. We've analyzed the data on 287 of them to date. And this is a scatter plot that shows the antibody titers in the mother on the x-axis against the cord blood in the y-axis. And you can see that the values are highly correlated. The mean maternal antibody titer is 11.4. The cord blood antibody titer is 11.8, and the ratio was 1.03. And to put this in perspective, this was what it looked like in a study that we performed in Bangladesh a couple of years ago, which looks very similar. And in that study, we found a transfer ratio of 1.01. So this is a table of the baseline characteristics of the subset of infants for whom we've tested the antibody to date. So and this is divided by mother-infant pairs with an antibody transfer ratio of less than 1 versus greater than 1. And so the first thing you can see is that 56, or 20%, of the mother-infant pairs had impaired antibody transfer with a transfer ratio of less than 1, and that 28 of the infants in the study had RSV, which was very similar to the percentage of the overall population. And we found no significant difference in most of the baseline characteristics between the two groups, including maternal education, parity, the number of other children in the household, preterm birth, low birth weight, or breastfeeding. We did find that being small for gestational age was associated with a higher antibody transfer, while being male was associated with lower antibody transfer. We wanted to look specifically at the impact of preterm birth and low birth weight on antibody transfer in this population because we have so much of it. So 26 of the infants were born preterm and 48 were low birth weight. And we found no significant difference in the maternal cord or the ratio between any of the three populations. So this is a graph that shows transfer ratio by gestational age at birth. And we would have expected that transfer ratio would have gone up as the infants became more full term, and we did not find that to be the case. So here you can see that of the 8 infants who were born before 35 weeks gestation, that the mean transfer ratio is 1.01. In those born, the 17 who were born between 35 and 37 weeks gestation, the transfer ratio is 1.04. And those who were born full term, the 261, the transfer ratio is 1.03. And finally, what we wanted to look at was specifically whether or not higher antibody titers were associated with lower risk of RSV infection. And again, we also did not find this to be the case. So of the 28 infants with RSV in the 6 months of follow-up, the maternal RSV antibody titer is 11.5, the cord was 12.3, and the transfer ratio is 1.06. And there was no significant difference compared to the RSV negatives. Among the subset of infants who had RSV, we had clinical data on 27 of the 28. And we were able to look at whether or not there was a difference between infants with upper versus lower respiratory tract infection. And of the 8 infants with upper tract infection, their estimated antibody titer at the time of infection was 10.7. And of the 19 with lower tract infection, their estimated antibody titer was 9.9. So, and the numbers were very small, and there was no significant difference. We also wanted to look at whether or not a higher antibody titer delayed your time to first infection, as has been shown by Paul Gleason in the US in the 1970s. We also did not find this to be the case. Sorry, it's all negative data. And that there is absolutely no relationship between your cord blood antibody titer and the weeks since birth. So in conclusion, we found that transplacental RSV antibody transfer was efficient in the majority of mother-infant pairs in a rural South Asian setting. We found that higher cord blood antibody titers were not protective against earlier or more severe infection in the study, although the numbers of infants with RSV infection were small. The limitations included a small sample size, as well as lack of surveillance for asymptomatic RSV illness in these infants, and that maternal vaccine strategies will require establishment of a protective cord blood antibody titer against RSV infection in infants in diverse clinical settings. And this may require a titer above that, something that we can achieve with natural infection. So I would like to acknowledge, first of all of the study staff in the Sarlahi who helped perform the study, as well as all of my co-investigators, and then in particular Ed Walsh and Falzia Mary and Micah for spending the years to help us develop the RSV node assay at our institution. So thank you.
So that's a very nice study, Helen, and just a couple of questions. One is, I thought the information that you had about gender was interesting, and I'm wondering if you had thought about doing a multivariable analysis because you're worried about things like the relationship between male sex and preterm birth and those sorts of things.
Absolutely, yes. We haven't finished collecting all of the, we haven't finished doing all of the neutralizing antibody assays, but once we do all that, then we'll do the multivariable analysis.
Yeah, and also the other thing is, in terms of delay or lack of delay for RSV infection, seasonality is an important confounder in all of that, and I know these analyses are complex, and you're probably right in the midst of doing that too.
Right. Right. So we thought about looking at that in particular, but the numbers are so small right now that we can't make any conclusions based on that. So if we do restrict only to the infants who were born and accrued follow-up time during RSV season, that would be the correct way to look at this. So we would compare those against the ones with and without RSV infection in that same study period, and then we would adjust for the baseline differences between those two groups. But I don't think we're going to end up having the numbers to do that. So unless one of the options is that we could then go back and test all of them. We have about 700 maternal samples. We just are limited in the number of cord blood samples. And so if we assume that the maternal and the infant cord blood are correlated, we can go back and test those 700 and then or just test the ones where the infants were alive during RSV season, then we could probably do that comparison. So.
Helen, I know this is a lot of work, so very well done. But I have a concern in the sense that the study was conducted under the umbrella of an influenza study. Mm-hmm. And so the issue of catchment for RSV may have been substantially missed because you don't have very high levels of infection that you're seeing for RSV, and we would have expected substantially higher numbers.
That's right.
And so I wonder if you could tell us a little bit more about what triggered to get a sample for evaluating viruses.
Right, so it was the presence of any symptom in the last 7 days, and the symptoms were fever, cough, difficulty breathing, runny nose, wheeze, or what they call the drippy ear, otorrhea. So any one of those symptoms. And we looked back to see if we had incomplete capture, and 95% of the infants who had these symptoms had a respiratory swab taken. So.
Was fever, though, a major driver, or you could obtain the sample without the presence of fever?
Fever was one of the criteria. So any one symptom would trigger a swab.
Thank you, Helen. That was very nice. Do you maybe you mentioned it, but you had so much data that I was overwhelmed. Do you have data on when the event occurred, the RSV infection, and the time of delivery? So can you correlate the cord blood titers with the time that the acute natural infection occurred in the mom?
We did. We the information, the side-by-side box plot I showed was the estimated antibody titer at the time of infection. We estimated that based on their cord blood titer and the time from their birth until the time of their infection.
I meant the mom. Do you have data on the mom?
I do have data on the mom.
So
Moms. Go ahead. What were you saying?
No, that's what I'm. So I'm just thinking on the Novavax studies, right? And when they immunize and when they transfer. So do you have any comparison with natural infection of when the event on the mom occurred and the antibody titer on the cord blood?
Yes. So we only collected swabs in pregnant women if they had a febrile respiratory illness. So we know that 14 out of the 3,700 pregnant women in the study had a febrile respiratory illness. We don't have serum samples on those 17 or 14. I don't remember. So, yeah.
Thank you. Thank you.